And then I also, okay, all right, good. I also have to bring up my chat box. So Javelle, I'll try to watch my chat box, but if I miss it a little bit, that would be great. Okay. Okay. All right, everybody. I am going to go ahead and start. My topic today is dyspnea. What to do when you're called to see someone who's dyspneic or short of breath. Probably one of the more common calls that you'll get in the hospital, one of the most common symptoms that you'll have to deal with. And for today, I mean, obviously there's a lot to talk about with dyspnea. I want to talk a little bit about mechanisms of dyspnea, not too much, just a little bit. Talk about bedside evaluation and talk about emergency care. And we'll run through a few cases as we do that to sort of make some of these points. Dyspnea is it's shortness of breath, but if you try to sort of get a little bit more specific, dyspnea is really an abnormal or uncomfortable sensation of breathing, nothing more than that. It's very subjective. And it's this subjective experience of discomfort that, and as you've talked to patients, I'm sure you get this, it's comprised of qualitatively very distinct sensations that can vary in intensity or sometimes even be absent, even in the setting of respiratory failure. But it's very variable person to person. But it's nothing more magical than, you know, an abnormal or uncomfortable sensation of breathing. And the interesting thing, and also the difficult thing about dyspnea, is it's sort of a final common pathway, right? I mean, look at all these different types of patient scenarios. A type 1 diabetic with nausea and vomiting, you know, a man with alcohol use disorder with an acute GI bleed, chronic liver failure with ascites, CHF, pneumonia, PE, pneumothorax, COPD. Why do all these people have the same symptom? And because they have the same symptom, how am I supposed to tease all these very different things apart? And, you know, the respiratory system, which I think is pretty cool, is designed to maintain homeostasis with respect to gas exchange and acid-base status, both gas exchange and acid-base status, with the least amount of work possible, designed to maintain homeostasis with the least amount of work possible. And any derangement in that balance of gas exchange or acid base, or in the work required to maintain that homeostasis, can result in dyspnea. And that's how I think about it. Nothing really more than that. And yet, when you think about all the different components then that are required to maintain that homeostasis with the least amount of work, it goes from the brain to the spinal cord to the nerves, the muscles, chest wall, diaphragm, pleura, airways, alveoli, heart, blood vessels, you know, blood cells, mitochondria. Those really are all the components of the respiratory system. One of the reasons that I really love respiratory physiology is look at all the things it actually involves. It literally is not just the mechanics of bringing air into and out of the lungs. It's really about gas exchange and acid-base status, all the way down to the cellular level, from respiratory drive to the cellular level. It's really pretty cool. Okay, I'm a little amped up on my caffeine this morning, but nevertheless, I'm a respiratory nerd. So, so again, pathophysiology of dyspnea. Dyspnea occurs when there's increased central drive. Regardless of how good the blood gases are, if there's increased central drive, either from some neurologic disease or other disease, some medications that people might be taking, or psychogenic increases in central drive, patients will complain of dyspnea. If there's an excessive amount of respiratory muscle work, if the muscles just have to work harder, again, even if gas exchange is fine, that will result in dyspnea. If air doesn't flow well through the lungs, or the lungs aren't stretching very well, so think about obstructive lung disease and restrictive lung disease, that results in dyspnea. And then at the metabolic level, oxygenation of the blood. So if you're hypoxemic, obviously, that's what we usually think about when we think about dyspnea. But we also have to think about tissue hypoxia, not just hypoxemia, and then CO2 clearance, hypercapnia, and of course, acid production, metabolic acidosis. So again, we have to think about all this, and all those things are all included in the pathophysiology of dyspnea. So let's just jump right in and get to a case. So you're the night medicine intern. Maybe some of you are on that right now, or will be. And a nurse calls you at 2:30 in the morning to report that Ms. Petunia Keo, Kilo, I can't pronounce French very well, a 68-year-old woman who was admitted 5 days ago for community-acquired pneumonia and a mild COPD flare. She's been in the hospital, has worsening dyspnea. The nurse asks you what you'd like to do. So you check your sign out. Come on, advance, there you go. Okay, so here's your sign out list. Sort of, I rearranged it a little differently. And you look at this and you're like, oh my goodness. She had pneumonia, she has COPD, she has a history of coronary disease, a history of CHF, she's had a DVT, she's on IVs, IV antibiotics. Oh, and look, they put in a subclavian line today. Yikes, my differential for her dyspnea is pretty long and pretty varied. Maybe her COPD is getting worse, maybe her pneumonia is progressing. Maybe she got a pneumothorax, delayed pneumothorax from the central line. Has she gotten into pulmonary edema from all the fluids from the IV antibiotics and the sodium and the piptazo that she's been getting? Maybe she had a PE. And so, you're like, where do I start? So what would you do next? And we're going to put up a poll, I think, for this question. Would you order furosemide? Would you order a CT angiogram? Would you first go see her? Would you stop her IV fluids? Or would you activate the cath lab? Go ahead and then Javelle, do you put up the, oh, there we go. One person put order furosemide, and that was me. Javelle's laughing at me. I played in the poll too. Yes, of course, you're gonna go see her because you just have to, right? So, but as you've been called, as you're on the phone, you want to start asking for some additional data before you even get there. Ask for vital signs, not just shortness of breath. Are there abnormal vital signs? What's the oxygen saturation? Mental status and sort of physical distress, I find incredibly helpful for me to rapidly triage a patient with dyspnea. And then what was the background? Did something just happen? Did she just get a new medication and she's having an allergic reaction? Or did this come on gradually, or did it come on suddenly? And also be thinking prior to your arrival, as you're making your way to the bedside, what else do you want to do? Do you want to put her on oxygen? Do you want to put her on a cardiac monitor? Start an IV. This woman already has an IV, but not all patients will have an IV. Do you want to give an empiric albuterol, beta agonist, while you're on your way? Do you need a blood gas, ECG, chest X-ray, et cetera? So hopefully your mind is suddenly starting to go. But of course, as we said, you have to go see her. So here you get there, and here's what she looks like. She's actually in moderate respiratory distress, but she is awake and alert and conversant. She's afebrile. Her heart rate's 108. Her blood pressure is 128/67. Respiratory rate's up 24, and her SAT is 91% on 4 liters nasal cannula. So safe, but not normal. She doesn't have any jugular venous distension. And when you listen to her lungs, she has some right basal crackles, occasional soft wheeze, but she has pretty good airflow. She has bilateral pretibial pitting edema, but it's a little asymmetric, 1+ on the right, trace on the left. So not a poll, but think, what would you order next? What would your very next step be? And if you want to throw it in the chat, great. If you want to shout it out, great. But yes, VA interns, chest X-ray, exactly. So we're going to get a chest X-ray. Now, one of my very best friends is a chest radiologist. And he loves to give me a hard time for the reasons we put when we need a chest X-ray. So please, on his behalf, please don't order the chest X-ray this way, which stands for follow-up, of course, but looks a little funny, or worse, that. Okay, enough about that. Sorry. Okay, Eric, I did your. So here's the chest X-ray. Right lower lobe focal opacity, but it's actually unchanged from admission. So it doesn't look like the pneumonia is progressing. No evidence of worsening heart failure or pneumothorax. Blood gas, you get a blood gas, 748/34/62 on 4 liters nasal cannula. And her baseline on admission with her mild COPD exacerbation was 739/43/78. So she's a little more hypoxemic, and she's got a little bit more of a respiratory alkalosis right now. And you get an ECG because of her history of coronary disease. And there's no ST segment changes, no ischemic changes, no changes from baseline. So now what next? What are you going to do next? And while you're thinking about that, I want to give you this is one of the main messages of the talk, my 3 pillars of care for patients with dyspnea. The first pillar is your safety net. Get your safety net in place, get them on oxygen, get IV access, get them on a cardiac monitor. And you can often do that as you're going to see the patient. You can sometimes do that over the phone. Make sure that you get all your vital signs, including assessing oxygen, so a SAT, even, and maybe a blood gas, but a SAT. And then mental status. Please include mental status when you're thinking about people with dyspnea. And then you're going to run through your dyspnea survey, A, B, C, D, E. So safety net, assess vital signs, and then go through your dyspnea survey. And the dyspnea survey looks like this. A is for airway. And there are patients who have partial airway obstruction, and that can be upper airway obstruction or a mucus plug, a lower airway obstruction. And these things absolutely develop. And so never forget about airway obstruction. B is breathing for the lung. And those are all the lung diseases. So asthma, atelectasis, pneumonia, a pneumothorax, other processes like that. So lung parenchymal or pleural problems. C is circulation, the cardiovascular system. So, are they profoundly anemic? Are they having an arrhythmia? Are they in heart failure? Have they had a PE? Do they have a large pericardial effusion and tamponade maybe? D is neuromuscular deficits, and there are people who can have rapidly progressive neuromuscular processes, and either you can have chronic, but also rapidly progressive neuromuscular stuff. And then E is the electrolytes and all the extra stuff, and so acidosis, sepsis, electrolyte disorders, really bad hypokalemia and hypophosphatemia, sort of that crosses over into deficits that can give you muscle weakness, large ascites, pushing up on the diaphragm, etc. So be running through this list as you're assessing people. Dyspnea survey, A, B, C, D, E. And then with this woman, we already talked about the differential. Maybe it's her COPD, pneumonia, the chest x-ray didn't look worse, pneumothorax, that didn't show up on the chest x-ray, heart failure, didn't look like that, your exam didn't really look like that, ischemia, PE. So you still have some of these things on the differential. And so now, next poll question, now what would you do? I won't play this time. Don't want to skew the results. Calculate a pretest probability of PE, order a BNP, order a D-dimer, order a CT angiogram, order a VQ scan, or order an echocardiogram. Nice. So I'm guessing from this that most of you are worried about pulmonary embolism, because a lot of these tests, VQ scans, pulmonary angiogram, pretest probability, you could even argue D-dimer and a BNP and an echo, while also assessing the heart, the BNP and the echo also can be used. So good. So let's go through some of those things and talk about that. There are several prediction models in the literature for pulmonary embolism. This one is the Wells clinical prediction model, one of the first, I think the first actually, that was studied, validated. A lot of studies have looked at this. There's now a modified Wells, Wells 2, I think they call it. And here are the items in the table and the points assigned. And then you decide low clinical probability, moderate clinical probability, or high clinical probability based on the number of points. So this woman, she has some signs of DVT. She's got asymmetric pulmonary lower extremity edema. This next one always bugs me about the Wells model. It says alternative diagnosis less likely than PE. So they're asking you for your clinical gestalt, which, wait, that's what we use the prediction model for. So there is this subjective component to the Wells model that always troubles me a teeny bit. And we may give her 3 points for that, depending on our clinical suspicion. She had a heart rate over 100. She's been in bed for the last 5 days. And then, so actually the question from the VA, history of malignancy, if it was more than, 6 months ago and there's no active disease, it does not count in the Wells model. So just like a distant history of cancer without known active cancer does not count. And the woman had a previous DVT. So she suddenly has 7.5 points. Even if you don't give her the other 3 points, that puts her into the high clinical prediction model, the high pretest probability for PE. So your instincts were good. Here's the revised Geneva score. I like this one more because this one takes away that subjective element. And again, different risk factors, symptoms, clinical signs, and then again, the signs points. And she's over 65. She had previous venous thromboembolism. Her heart rate is greater than 95. She had lower extremity edema. And so her score is 13, and again, puts her into the high pretest probability, again, validating everyone's thoughts that this might be a PE. D-dimer is best used when your clinical suspicion is low. If you have a low pretest probability and a negative D-dimer, you can stop. There have been a lot of studies that show that that's when it's best used. If you're going to get a study regardless, then certainly no need for a D-dimer. And a positive D-dimer is not specific. It's not diagnostic. So many other things can cause a positive, an elevated D-dimer, but a low D-dimer with a low pretest probability is fantastic. There's a lot of controversy about whether you can even use it for inpatients, because it's mostly been validated in the clinic and in the emergency department when people present with dyspnea. So once people, have something inflammatory going on, like pneumonia, and they've been in bed for a few days, their D-dimer is likely to be elevated anyway. So it's probably not super helpful in that setting. Why is clinical scoring necessary, though? And I want to share these data from the PIOPED-2 trial, which now is getting a little bit long in the tooth. But this was a study where they looked at the clinical probability of PE and the CT pulmonary angiogram findings, and then everybody got an invasive pulmonary angiogram. That was the gold standard in this study. And here what you see on the x-axis is the probability score. They used Wells, low, moderate, or high. Here on the y-axis, true positive, and on the z-axis, whether the CTA was negative or the CTA was positive. And obviously, if you have a high pretest probability and you have a positive CT angiogram, it's positive. And even if you have a moderate pretest probability. But look in the corners. If you have a low pretest probability and the CTA still reads out some small PEs, there's only a 38% chance that those are true positive. There were a lot of false positives in people with low pretest probability. And similarly in this corner, people with a high pretest probability but a negative CT angiogram, 39% false negative rate. And so you still really need to do your pretest probability in order to best assess your CT angiogram results. People have forgotten these data, and I think they're very important. Now, a very large central PE the data may look different. But for smaller subsegmental PEs, sometimes they're overread or missed. But here's this lady's CT. This is this woman's CT pulmonary angiogram. And I think you can see a very large clot there on the right and a fair bit of clot burden there on the left. So she, in fact, did have pulmonary embolism. So again, diagnostic strategy, determine your pretest probability. I've shown you Wells and the revised Geneva score, but there's the PISA model, the Padua model, the PERC model, which is used a lot by our emergency medicine colleagues. I find that almost a little too simplistic, but nevertheless, you'll find all of these in your iPhones under MD Calc. They're all in there, and just use one or two of them and get used to that one in particular. I actually don't know if data really saying one is much better than the other. Get basic studies, a cardiogram, a chest X-ray, maybe a blood gas or a venous blood gas. D-dimer, probably not helpful. Follow a diagnostic algorithm so you don't get lost. And then decide, we rarely do VQ scans now, but there are times when people have contrast allergies or can't go down to CT, and the nuclear medicine folks can sometimes come up to the bedside. Sometimes you can just do a lower extremity duplex, because you know what? If you have a clinical suspicion for PE and the lower extremity duplex, which is a non-invasive study, no contrast, and it's positive, boom, you're done, anticoagulation. And then always ask yourself in the middle of the night, do I start anticoagulation while I'm waiting for the results of these tests? And that's another place where your pretest probability can really help. If you have a high pretest probability, then, and the person doesn't have an absolute contraindication, then start anticoagulation while you're doing the workup. Because the reason people die from PEs is usually not from the initial PE, it's from a subsequent PE. So really get them on anticoagulation as best as possible. Okay, questions about that? Wait, what is the, oh, that's a super good question. And I don't think there's to my knowledge, there's not a literature-based cutoff. It's for people with chronic kidney disease. I hear radiologists talk about estimated GFRs less than 30, less than 20, but you know what? If they already have chronic kidney disease and they are already on dialysis, you're not going to dialyze off the contrast, by the way. That's a little bit of a clinical myth, but their kidneys, if they need the CT, they need it. So some of those cutoffs are relative and not absolute, and differ a little bit by radiology group, as best I know. So thank you, good question. I may look that one up to see if there's more evidence about that, and I can email everybody. Okay, case number 2. You're again the night medicine intern. It's the next night, or maybe it's just an hour later. The nurse calls you at 3:30 to report that Mr. William Power, a 65-year-old man, admitted early today for anemia of unclear etiology and COPD, has worsening shortness of breath. Nurse asks you what you like to do. You check your sign out. Here's your sign out. And whoops, here's your sign out. And you can see a lot of different things on here already. And so when you go through your dyspnea survey, and does he have worsening COPD? Does he have pneumonia? Did he aspirate? Is his anemia getting worse? Does he have heart failure, ACS, sepsis? These are some of the things, that sort of pop up, from some of these things going on. So, what would you do next? Order Lasix, 2 units of red blood cells, order a Coombs test, activate the cath lab. No, you're going to go see him. It's the same right answer to the earlier question. So you you go to see him, and He's an older man. He looks acutely ill. He's a little bit overweight. He's alert and oriented ×3. His heart rate's 110. His blood pressure's up, 160 over 105. His respiratory rate's 22. His temp is 38.1. Sats are 89% on room air. And he's got respiratory distress. He's diaphoretic. He's working hard to breathe. He's got wheezes and rhonchi with scattered crackles and a really prolonged exhalation phase. Let me just move my chat box. He's got no JVD. His heart sounds are pretty distant, no peripheral edema. And how would you care for him now? What do people think? I don't think I have a poll question for this. I do have a poll question for this, though. So as you were thinking about that, what would you not order now? Would you not order spirometry, a blood gas? Yeah. Adrian's thinking this sounds like maybe a COPD exacerbation. Would you get spirometry or peak flows? Would you get a blood gas, repeat hematocrit, chest x-ray, oxygen? Which would you not order? Sorry, very important. Which would you not order? Zainab, I like that. Give oxygen. Yeah, not order a chest x-ray. Yeah, a few people would not immediately start oxygen. That's a good thought. Repeat hematocrit, blood gas, bedside spirometry is the majority of you would not order. And that's correct. In patients with asthma, especially younger people with asthma, there's a lot of literature about monitoring peak expiratory flow rates, peak flows. That's not really helpful in the setting of an acute COPD exacerbation. So we're not going to order the spirometry. Let me give you the data for the other things. His blood gas now is 729, 54, 58 with a bicarb 27. So he's got a bit of a respiratory acidosis with worsening hypoxemia. His repeat hematocrit's 21%, so it's not that he's getting more anemic. And a chest x-ray was ordered, and he's got hyperinflation, but no new opacities or pulmonary edema. So again, sort of all very consistent with a COPD exacerbation. I don't want to spend too much time on COPD exacerbations. There's you do want to give oxygen. There is a lot of controversy about, not controversy anymore, a lot of information about not giving too much oxygen in patients with COPD. You're going to give emergently bronchodilators, rapid acting bronchodilators, short acting bronchodilators, albuterol and atrovent. Corticosteroids, which you're going to give either in the ICU or the non-ICU or outside the ICU. But the study that everybody talks about, the 5 days of 40 milligrams of prednisone, that was a non-ICU study. So sometimes we give higher and longer doses in the ICU, but at least you're going to start for non-ICU patients like this one with 40 milligrams of prednisone or IV methylprednisolone if person can't take PO. Limited spectrum antibiotics like azithromycin, doxycycline, those have been studied, and they actually do, even in the absence of sputum cultures, they actually have been shown to shorten COPD exacerbations. So I have a low threshold, especially if the person has a kind of a, kind of a chronic bronchitic component. I have a low threshold to start azithromycin or doxycycline. Diuretics, as long as the person's kidneys and blood pressure are okay, always kind of help. Dry lungs or happy lungs, as those of you who work with me in the ICU will learn as a mantra. And then non-invasive ventilation, fantastic for COPD. And then sometimes people have to get intubated. And so again, other considerations, bedside spirometry, usually not helpful. A blood gas, either arterial or venous, usually needed because you really want to assess the ventilatory status, the PCO2 and pH. The oxygen status you can do with a sat meter. Chest X-ray and ECG usually are needed because COPD and coronary disease run hand in hand, and you can often be confused. And then you, of course, consider the other usual things. Okay, good. COPD exacerbation. Let's talk just for a second about oxygen saturation goals. And you may have already learned this year or in medical school, but like with many other things in medicine, we're learning that less is more. And so for most patients with hypoxemia, SATs 90 to 94% is a reasonable target. There have actually been some studies in some patients, including those with acute myocardial infarction, that higher levels of saturation, giving oxygen, if they do it on their own, that's fine. But if their SAT's 94 and putting them on oxygen to get their SAT above 96 actually led to worsened outcomes. Isn't that interesting? So we're tolerating lower saturations. In patients who have very profound anemia, either an absolute anemia or a relative anemia, then driving the saturation up higher in those settings makes good sense, because you're really trying to increase oxygen delivery to the tissues, and you have very few boxcars, you have very few red cells. And so you really want to saturate them as best you can. And in patients with COPD who are risk for CO2 retention, you really kind of want to know their baseline. There are some patients who in their best day in clinic have SATs of 87%. And so that's fine when they come in the hospital. But for most people, it's lower than the 94%. We target 88 to 92% in most patients with a COPD exacerbation, because leaving them too hypoxemic is bad too for their brain and their heart and other things. But over-oxygenation is also problematic. Okay, let's go into case 3. An
question in the chat.
Oh, sorry. How often would you repeat a blood gas in a patient with an acute COPD exacerbation? Super good question. I think outside of the ICU, if the patient is responding clinically, their heart rate's coming down, their mental status is staying clear, they feel less short of breath, their wheezing is getting better, I don't think you need to repeat one, in all honesty. In the ICU, if someone's intubated, or if they're on non-invasive ventilation and it's harder, they're more tenuous, then I will usually repeat a venous or arterial blood gas 4 to 6 hours later to make sure I'm going in the right direction. And then other standards are sort of based on if they're on ventilators and what you do for people on ventilators. I think it's always helpful to have a baseline estimate of someone's PCO2 and pH. But sometimes even at discharge, they're not quite back at baseline. So we talk a lot about getting a pre-discharge blood gas. I actually think it's better to wait and get it at the first clinic visit, because people are not always back to their baseline at the time of discharge. I hope VA interns, I hope that helps answer that question. So again, clinically outside the ICU, they may not even need a follow-up blood gas. Okay, 82-year-old man with a history of dementia. He's admitted with fever. He's got a fairly large decube over his sacrum. He's getting wound care. He's on Pip-Tazo. He's getting tube feedings, and he's got dyspnea. You're called to come see him for dyspnea. and you're trying to think, oh, what's the differential in this guy? And you're thinking airway. Well, he's kind of in bed, not moving a lot, getting tube feedings. Maybe he has a mucus plug. Maybe he aspirated. Maybe he's got pneumonia. Maybe he's volume overloaded. He's getting all those antibiotics. Maybe he had a PE. Maybe he's just getting tired, respiratory muscle fatigue, sepsis, overfeeding, sort of people on tube feedings. If they have fixed lung function, like they have a reduced lung function and you give them too many calories, they get short of breath just because they have to breathe off that extra CO2. So that's kind of what you're thinking. So you go see him. He's somnolent, but he's arousable, in moderate respiratory distress, working hard to breathe. His respiratory rate's 38. He's febrile, 38.8. His heart rate's 110. His blood pressure is a little soft, 95/67. His SAT is 97% on 4 liters nasal cannula. No JVD. His lungs have a few bibasilar rhonchi, but no crackles, no wheezes, and he just has some trace pretibial symmetric pitting edema. Whoops, I did that by accident. Oh yeah, okay. So here's some data that you collect. His chest X-ray, clear, no pneumonia, kind of lowish lung volumes, but no pneumonia, no evidence of aspiration. His ECG, sinus tach, no ischemic changes, no changes from baseline. Now what? What other data do you want? How are we doing on time? His blood gas is this. Hopefully that was 747, 2589. So he's oxygenating well, but he's got a respiratory alkalosis. How about a BMP? Let's get that. Yeah, CBC, blood cultures, CBC, awesome. His white count was elevated, actually, and blood cultures were drawn. Here's his BMP, 144, 3.2, 106, 18, 38, 1.7, 168. What do you notice about this set of electrolytes? Yeah, the renal function's up a little bit. Yeah, the blood sugar's up a little bit. What else do you notice? Anybody notice something big? Low K, good. Yes, gap. Anion gap metabolic acidosis. He's got a gap of 106, 108, 124, 20. His anion gap is 20. So even though his pH is high, he has an anion gap. And he has a primary respiratory alkalosis and an anion gap metabolic acidosis. And that is classic scenario for sepsis. Early sepsis, the cytokines in early sepsis trigger the central respiratory drive. And they actually initially, if you could monitor someone through their course of sepsis, they actually initially get a respiratory alkalosis. And then as the lactic acidosis increases, then their pH goes down. And so don't forget that combination, even if the pH looks alkalemic. This guy is septic. His lactate level was elevated about 4.5, 4.8, something like that. Yeah, if I remember correctly. And he was in fact septic. And people with sepsis can present with shortness of breath. Fantastic. Awesome. Okay, last case. This one's a good one, but you guys are going to nail this. I know it. You're on long call. You get paged to the emergency department. This is a real case from that I took care of a few years ago here at the U. You're on long call. You get paged to the emergency department at 10:58 p.m. Oh, 2 minutes before the cutoff. Really? What? And you get asked to admit Christy Leeds. Christy's a 37-year-old woman. She has lupus. She has Evans syndrome, which is an autoimmune hemolytic anemia and autoimmune thrombocytopenia. That combination is referred to as Evans syndrome. Bud Evans, by the way, was a physician at the Seattle VA when he described Evans syndrome. And And so she's recently had flares of her autoimmune hemolytic anemia requiring very aggressive immunosuppression, MMF, Cytoxan, Rituxan, and steroids, really a difficult hemolytic anemia. And her baseline crit hovers around 18 to 21%. She comes in now with severe progressive dyspnea on exertion that's associated with chest heaviness and lightheadedness. But in the ED, her hematocrit's 19%. It's at her baseline level of anemia, and you're called to admit her. So on exam, as you take a history and exam, here are her current meds. She's still on her MMF, prednisone, dapsone, and folate. She's awake and alert, slightly increased work of breathing. She's afebrile, she's tachycardic, 106. Her blood pressure is normal, 130/84. Respiratory rate is increased at 20. That's not sort of the default 20. She really was breathing at 20. And her SAT, her pulse oximeter, was 89 to 91%, kind of bouncing around in there on low flow oxygen, and didn't really change as you went from 2 up to 5 liters. No JVD, her lungs were clear. She had a systolic ejection murmur, no gallop suggesting heart failure, and she had no cyanosis or peripheral edema. Here's her initial data. Her chest x-ray was completely clear. Sinus tach, no acute changes. Her hematocrit, I told you, was 19%. Her blood gas, 737, 31, 92 on the 2 liters nasal cannula, but at the time her SAT was reading 90%. And her basic metabolic panel was this. So she had a gap of 18. She had an anion gap of 18, normal renal function, pretty much normal electrolytes. So be thinking, what next? Yep. What would you order next? And this is our last poll, a CT pulmonary angiogram. Would you transfuse her 2 units of red cells? Would you intubate her for impending hypoxemic respiratory failure? Order a repeat blood gas with a co-oximetry panel? Order blood cultures and start broad spectrum antibiotics? I love it. Look at that. Yeah, this one was pretty confusing. She's obviously immunosuppressed, so we were worried too about sepsis. Intubation, she was really protecting her pH, and her PO2 was 92. Her SATs were low, but her PO2 was 92. And so we felt like we had some time there. She was at her baseline level of hematocrit. It didn't look like her hemolytic anemia was flaring, but we definitely wondered about just giving her some extra boxcars. And a pulmonary angiogram, yeah, she could have had a PE2. But the blood gas with co-oximetry panel, which 40% of you picked, is what we did next. And here's what we found. Drum roll, please. She had a MET hemoglobin level of 19.6. 20% of her hemoglobin, which was already low. Sophie, yes, it was the dapsone that she was on for her PJP prophylaxis because of her immunosuppression. and she had dapsone-induced methemoglobinemia, and with a methemoglobin level. So again, 20% of her hemoglobin. So even though her hemoglobin, her hematocrit was reading 20%, you know, it was really like she had a much lower crit, a very relative anemia. And I see the question about a co-oximetry panel, but we treated her methemoglobinemia with methylene blue, and she got better, and her dyspnea went away as her methemoglobinemia resolved. A co-oximetry panel is it's another arterial blood gas that you send to the lab. You actually have to ask specifically for that term, and they will measure directly the amount of oxyhemoglobin, carboxyhemoglobin, and methemoglobin. And they call it a co-oximetry panel. And I can't tell you why the lab medicine people call it that, but it's rather than just an indirect pulse oximetry, it's a directly measured oximetry, if you will. But they're measuring carboxyhemoglobin, methemoglobin, and oxyhemoglobin. So yeah, so her oxyhemoglobin level would have been 80% instead of much higher. And so cool, a case of methemoglobinemia presenting as dyspnea. So cool, great case. Okay, so in summary, please don't forget the non-cardiopulmonary causes of dyspnea. They're so important. Sepsis, both absolute and relative anemias, ascites, neuromuscular disease, anxiety, and metabolic acidosis. I couldn't find a good image for metabolic acidosis, so I put up an image of a lemon because that's how you add acid to food. So anyway, thank you, everybody. We've talked about the mechanisms of dyspnea, some of the bedside evaluation and emergency care. And then we talked about these 3 pillars. Get your safety net in place. That'll keep the patient safe. Get vital signs as the first part of your assessment, including mental status. And then do your dyspnea survey, airway, breathing, circulation, deficits, and electrolytes and extras. You'll be able to diagnose the vast majority of patients just like you did this morning. Thank you so much for your attention. I really, really appreciate it. Have a great rest of the day. Those people are also dyspneic because they're up at altitude, but they're happy, not sad.
All right, everyone. In case you missed the QR code this morning, I put the attendance link in the chat along with the evaluation link. So please complete those before you leave. And then have a great morning.
Yeah. Thanks, everybody. I hope it was a little helpful.